the acute heart failure management. Heart failure being a huge topic, I chose to divide it into two sessions. I will talk today about the acute heart failure management, and then later on, if we have time, inshallah, and chance, we can talk about the chronic heart failure management, and we will have some MCQs about it as well. So let's get started. So my talk will be divided into two parts. The first part, I will be doing most of the talking, where I will just go through some points about or just briefly about the management of acute heart failure. And mainly, the source I use is the European guidelines. And then we will go to the second part, where you guys will be the one doing the talk, because it will be just a quick exercise, MCQs, about the management of acute heart failure. And just to be inclusive, I try to bring the questions or use the source of the American guidelines in the MCQ, so we can go over both of them. There are no major differences, but there are some differences that we can just focus on. You can interrupt me anytime with any questions, and then we also at the end we will open the floor for any questions you have. So just to start, we'll start with the definition. So acute heart failure is the rapid or gradual onset of symptoms or signs of heart failure that are severe enough for the patient to either seek urgent medical advice and requiring admission, or only an emergency visit. And usually patients will require either the initiation of a new treatment or an up-titration of the treatment that they already are on, and mostly they will need an intravenous management. So the acute heart failure can be either like a first manifestation, a new onset heart failure, but more frequently, I'm sure you encounter the type of patients who are already diagnosed with heart failure and coming with acute decompensation more often than those with new onset. But in general, acute heart failure refers to these two types. So now going to the, just an easy way to refer to acute heart failure, we can call it, or we can remember the 3 F's of the acute heart failure. So it is frequent, it is fatal, and it's formidable. It's frequent because it is the leading medical discharge diagnosis in the US. This is based on US data. The length of stay is remarkable. It requires, on average, 5 days of hospital stay, and even more in some countries. For example, here in Saudi Arabia, in our institution, the average length of stay is up to 8 to 9 days. So it is even more than the average elsewhere in the world. And this has a major financial impact and economical impact on the healthcare system. It is also fatal because it has a 4 to 7% mortality in hospitalized patients. Within 30 days, the mortality is up to 14%, and 1 year mortality is approaching 40%. So it has such a high mortality with each admission as well, with each acute decompensation. And it's also formidable. It's the readmission rate is really high. 1/4 of the patients will be readmitted within 60 days, within 2 months, and half of the patients will be readmitted within 6 months. So this is just to give you an idea what is the burden of acute heart failure on the healthcare system. So according to the European guidelines, European Society of Cardiology, the acute heart failure is the leading cause of hospitalizations in subjects aged more than 65 years of age. And it is associated with high mortality and rehospitalization rates. Actually, the in-hospital mortality, according to the European data, is reaching up from 4 to 10%. Post-discharge, 1 year mortality can even reach to 30%, with up to more than 45% deaths or readmission rates. So again, this is just to re-emphasize the huge burden of acute heart failure on the healthcare system. This is I like really this diagram. It summarizes the course of the heart failure patients. So it compares the clinical risk to the time table of the course of the disease. So basically, those patients who are class A, those who are only at risk of the heart failure, they spend like months and years before they get diagnosed. Once they get diagnosed, where they have the baseline heart failure risk, they get initiated on treatment, they get diagnosed and initiated on treatment. Then the treatment will be up titrated. They will be started on guideline directed medical therapy. Then they might need device therapy as indicated. They might need valve therapy, valve repair or replacement as indicated. Then they enter the phase where they have worsening symptoms and progressive symptoms with on and off acute decompensations. And with each acute decompensation, their prognosis is worsened until they reach the last stage, which is the advanced heart failure risk, where it is basically refractory, intolerant to guideline-directed medical therapy. The only options here would be transplantation, which is not widely available, mechanical circulatory support, or IV inotropic therapy. And if none worked, they will be for palliative care. So this is basically the course of the natural history of the disease. Another way to put it is also comparing the functional status to the time table of the disease. Those who are at risk will start off with a good functional status. They get diagnosed and then started on medical therapy. Then they start to have frequent decompensations, and with each decompensation, their prognosis is worse until they reach the last stage, where only transplant or advanced device therapy can bring them back to the initial functional status. So it is a terrible disease by all means. So let's start with how to diagnose the acute heart failure patients. So as we all know, heart failure is a clinical diagnosis. So we need to collect the patient's history, signs, and symptoms that are suggestive of acute heart failure. After that, we start with initial workup, which should include ECG, pulse oximetry, echocardiography, initial laboratory investigations that we will go through, chest X-ray, lung ultrasound if needed, and some other specific evaluations. But one of the most important diagnostic tools in heart failure is the natriuretic peptide. And we need to remember some cutoffs that are important in exams and also in our clinical practice. So we have the BMP and NT-proBNP. NT-proBNP is more stable, is less affected by some medications like Entresto, for example, ARNI. But we need to remember the cutoffs, especially those that help us to rule out the disease. I think we need to remember two numbers: BMP if it is less than 100, or NT-proBNP if it is less than 300. So basically, if we have these cutoffs, if it is less than these cutoffs, we can fairly exclude the possibility of acute heart failure. But we need to remember something, that whether BMP or NT-proBNP or natriuretic peptides in general, they are affected by other conditions, not only heart failure. So we need to remember that it can be elevated in pulmonary hypertension, for example, in renal impairment. In patients who are taking Entresto, BMP will be high. However, NT-proBNP will not be affected. We need to remember that age and female sex also can increase the value of proBNP and resulting in false positive values. And we need to remember also obesity. Obesity is the opposite. It can lower falsely lower the BMP level, and it can result in a falsely negative BMP or NT-proBNP. So we need to take into consideration the factors that affect the BMP and NT-proBNP other than the acute heart failure. And if it is more than 300, and along with the clinical symptoms and signs of heart failure, then the acute heart failure diagnosis is confirmed, and we need to do the further workup with comprehensive echocardiography. Again, anytime anyone has any question, just speak up, please. So this is the long list of investigations, initial investigations that we need to send for any patients who's newly diagnosed with or coming with acute heart failure. So we need to do an ECG, of course, because we need to rule out the possibility of any underlying acute coronary syndrome, because the management will be then different. Chest X-ray will be very important to confirm the pulmonary edema and congestion related to the acute heart failure. Also, lung ultrasound can be important in establishing any evidence of pleural effusion, for example, or pericardial effusion causing this presentation of acute heart failure. An echo, of course, would be very helpful in delineating the cause of the heart failure, whether it is valvular, whether it is reduced ejection fraction or preserved ejection fraction. NT-proBNP or natriuretic peptides in general, as we talked about, it can help in ruling out the diagnosis. Serum troponin will help in exclusion of acute coronary syndrome. And then we have other laboratory findings that are important in prognostication of the acute heart failure. So, for example, serum creatinine, electrolytes, and iron status all have important prognostic value, and we will talk about that later on, but they all have a prognostic value in those type of patients. Also, we need to send for a thyroid panel, TSH, because it is important it is class 1A indication actually to send for any patient newly diagnosed with heart failure to send for a thyroid panel, because it helps us to rule out any underlying hypo or hyperthyroidism, that both conditions can cause actually heart failure. D-dimer, and then we need to send for some labs to investigate some alternative diagnoses. For example, D-dimer, if we are suspecting any underlying pulmonary embolism that can mimic the presentation of acute heart failure, we need to send for procalcitonin if we are suspecting any underlying infection. Then we need to, as we will speak later, we need to know if the patient is hypoperfusing or not. Lactic acid will be very important. And lastly, pulse oximetry and arterial blood gases are really useful in managing these patients. So this is basically the most important initial investigations that we need to send for any patient with acute heart failure. So the clinical presentations. So basically, the clinical presentations of acute heart failure are of 4 phenotypes. Just to make it more interesting, I will go through some cases, and you guys, I want you to figure out what type of or phenotype of acute heart failure is the case. So before we go through the cases, so the most important question that we need to ask ourselves after establishing the diagnosis of acute heart failure are 2 questions. So is the patient congested, and is the patient perfusing or not? So congested, whether the patient is dry or wet, and if the patient is perfusing or not, whether the patient is warm or cold. This is very important in managing the patient. So let's go through the cases, and I want you guys to answer these 2 questions, whether the patient is congested or perfusing, and what do you think is the phenotype of the clinical presentation. So we'll start with the first case. So this is a 65-year-old gentleman with a prior history of acute anterior MI and ejection fraction of 30 to 35%, presented with gradual increase in dyspnea and edema in the lower extremities over the last 7 days after he ran out of his medications. He has CRTD implanted 2 years ago. On examination, he's afebrile, heart rate is 62, blood pressure is 110/75, saturating 93%, breathing ambient air. His GVP is elevated. His lungs auscultation, he had crackles at both bases. His heart auscultation showed 3 out of 6 pan-systolic precordial murmur, S3 gallop. His extremities showed lower limb edema, but he's warm to touch. His labs, hemoglobin is 8, sodium is 127, potassium is 4.5, BUN 42, and his creatinine is elevated. His ECG showed 100% AV pacing. So first of all, what do you think this patient is? Whether he's congested or not, or perfused or not?
Actually, this patient most probably it's warm and congested. That means it's
congested and well perfused.
Perfect, yes. So he's warm and wet, right? Perfect, excellent. So what do you think, what do we call this presentation? And this is actually the most common phenotype of acute heart failure. So this is basically an acute decompensated.
Warm and dry.
Yeah, so this is an acute decompensated heart failure. So this is the more, actually 75% of the patients to 80%, those you see in the ER, they will be coming most likely with acute decompensated heart failure. So what is acute decompensated heart failure? Mainly there would be an underlying LV dysfunction, or whether it is reduced ejection fraction or preserved ejection fraction. There would be sodium and water renal retention. The symptoms would be mainly of fluid accumulation. The onset will be gradual rather than an abrupt onset. And the clinical presentation, as we saw in this case, either wet and warm, and it could be also dry and cold. And the main treatment will be of IV diuresis. We will go through the treatment now. So basically, just before we go through the management, so these are the most common etiologies of decompensated heart failure or acute decompensated heart failure. It is non-compliance, and non-compliance, especially in our, I'm not sure about Sudan, but here in Saudi Arabia, it's most of the patients, it's the percentage of those who are coming with acute decompensated heart failure, most of them are precipitated by non-compliance, either non-compliance to medications or non-compliance to diet as well. So those who are non-compliant to salt restriction and fluid restriction also are considered in this category. Other precipitants include ischemia, inadequate pre-treatment, arrhythmias, hypertension, and some other also precipitants. But these are the most important. And I think it's really important to remember that non-compliance is always the main cause of any acute decompensation. So this is a very nice algorithm in the European guidelines regarding how to manage acute decompensated heart failure patients. The first thing we need to establish that if they are congested or not, as we did, and then if they are hypoperfused or not. So if they are not hypoperfused, then it would be easy. It's class 1 indication to start on loop diuretics. Then if they are still congested, we either increase the dose of diuretics or combine them with another diuretic. And if still the patient is not improving, then we have the choice of renal replacement therapy. And lastly, if nothing worked, we will start the palliative care. However, if the patient was hypoperfused, then it is not only loop diuretics. We have another modality, which is class 2B in recommendation, which is the inotropic support. Then if the patient is still not improving, then we need to start on vasopressors. It's also class 2B. And then if the patient is still not improving, then we need to go to the next step, which is mechanical circulatory support, which is class 2A, combined with renal replacement therapy. And then lastly, if the patient is not improving, will be considered for palliative care. So this is for case 1. Then let's go to the second case, the second phenotype. So this is a patient who's 59-year-old, morbidly obese lady, non-hypertensive, presented with 1-day history of dyspnea. So 1 day only, it's an abrupt onset of dyspnea along with orthopnea and PND. On exam, she's tachypnic. She's also has an increased work of breathing, requiring 4 liters of oxygen by nasal cannula. She's hypertensive. She has raised GVP, trace lower limb edema, not that significant, but warm extremities. Her BMP is 800. And this is her X-ray. So what do you think? Firstly, is the patient congested or congested, and is the patient perfused well or not?
Yes, it is congested and perfused well.
Okay, perfect. So what do you think is the main phenotype of presentation here?
You mean the regardless on dryness and warm and this and wet and warm?
Yeah, this question we answered. Yeah.
Warm and wet heart.
Perfect.
Wet and warm, yes.
Perfect. But as we can notice, in the case, the patient
warm and wet
is not the patient is not like the previous patient, is coming actually with mainly an acute pulmonary edema. The patient does not have significant peripheral edema, mainly coming with an abrupt onset of pulmonary edema. With
this acute presentation.
Yeah, exactly. So this phenotype, we call it acute pulmonary edema. The first patient, which was gradual onset with peripheral edema and also pulmonary edema, that was acute decompensated heart failure, and which is, as I said, is the most common phenotype of acute heart failure. But in this patient, is coming with an abrupt onset of high blood pressure. Most likely this is a hypertensive emergency, and with flash pulmonary edema. So this phenotype is called acute pulmonary. One of the phenotypes of acute heart failure is acute pulmonary edema. So basically the mechanism is an increase in afterload, mainly because of an abrupt increase in the blood pressure, a hypertensive emergency, or it can be due to other causes as well, like valvular heart disease and so on. The main cause of the symptoms is the fluid redistribution to the lungs, not an actual fluid accumulation in the body, but rather redistribution of fluids. And as I said, the onset will be rapid, as we have in we saw in our case, and the main treatment will be diuretics and also vasodilators. So let's go on and see how to manage this type of patients, those who are presenting mainly with an acute pulmonary edema. So the first thing we need to start the patient is on, logically, is oxygen, or if the patient is requiring like non-invasive or invasive mechanical support, ventilatory support, then this is also class 2A. Then we have to ask ourselves if the patient blood pressure is fair or not, is adequate or not, because this will change our management. So if the systolic blood pressure is more than 110, then we will start loop diuretics, yes, but also we can consider vasodilators, because again, as we said, the main pathophysiology here in those patients is the increase of the afterload. That's why vasodilators would be useful in decreasing the afterload, and along, of course, with loop diuretics. In those patients, the fluid in the lungs is not mainly because of accumulation of fluids in the body, but it is rather the redistribution of fluids to the lungs, and that's why vasodilators would be useful. However, if the patient is hypotensive, if the systolic blood pressure is less than 110, of course, by all means, we need to avoid vasodilators, because this will just worsen the hypotension. Then also we need to ask ourselves if the patient is perfusing well or not. So if the patient is perfusing well, then we will just continue on the loop diuretics. If not, then we need to consider the inotropic or vasopressor support. And lastly, as with the previous phenotype, if everything failed, we need to go on with the renal replacement therapy, mechanical circulatory support, and device therapy. And lastly, palliative care if nothing worked. So let's go on to the third case. So this is a 67-year-old male, non-interstitial lung disease, presented with 3 days history of worsening lower limb swelling, abdominal distension, and pain associated with early satiety and orthopnea. On exam, he's vitally stable. He has raised JVP. He has clear lungs, increased abdominal girth with positive shifting dullness, and lower limb edema. But his extremities are cool to touch. So what do you think for this patient? Firstly,
not perfused well.
Not perfused, so he's cold. Yes.
It is on failure, yes, but it is not really.
Okay, so he's wet and cold.
Cold and wet.
Perfect.
Yes.
Perfect.
Cold
Excellent.
and wet. Yes, right.
Then the next question is, what is this phenotype?
It's mainly RV failure.
Perfect. Yeah, excellent. So this is mainly isolated right ventricular failure. So as we saw in the case, the patient has no pulmonary congestion. It is mainly symptoms of right-sided failure.
Yes, clear lungs. Yes.
Yeah. So the main mechanism is RV dysfunction, either due to like precapillary pulmonary hypertension, which is most likely in this case, the patient is having interstitial lung disease, or it can be due to other reasons, for example, ischemia, RV infarction, and so on. The main symptoms will be that of right-sided heart failure. And the main treatment will be diuretics and inotropic support, and also short-term mechanical circulatory support. So let's go through the algorithm for this phenotype. So those coming with RV failure, the first thing that and the most important thing to establish first is what is if there's any underlying acute coronary syndrome, RV infarction, or acute pulmonary embolism. Because if there is, we need to treat those conditions accordingly. And if no evidence of SAS or no evidence of PE, then we go on and treat optimize the fluid status of the patient. If there is marked congestion, then we need to start loop diuretics, obviously. However, sometimes if the patient is not that markedly congested, we might even need to start on careful fluid administration. Why is that? Because RV failure is a preload dependent condition. So sometimes to improve the cardiac output, we really need rather to start on fluid administration, but we need to be careful, of course. And it sounds counterintuitive to start someone who's coming with heart failure, to start them on fluid administration or fluid hydration, but in those particular patients, there's, as I said, they are preload dependent. So sometimes they can benefit from fluid administration because it will improve the cardiac output. But of course, if they are markedly congested, we will not start them on this modality. Then we need to ask ourselves if they are perfused well or not. So if they are not perfused well, then we need to start on vasopressors or inotropic support or mechanical circulatory support like RVAD and so on. And if they are perfused well, then the management will be mainly of IV diuresis. Now the last case, which is the last phenotype. This is an 81-year-old female, non-ischemic cardiomyopathy and multiple admissions over the last year. History of diabetes. She's also CKD, chronic kidney disease with a creatinine of 1.8, chronic atrial fibrillation and obesity. She presented with worsening dyspnea and lower limb edema. She's hypotensive with blood pressure of 78/50, with clammy cold extremities, altered mentation, and decreased urine output. So firstly, we need to establish whether the patient is congested or not. What do you think?
Sweat and cold.
Exactly. Excellent. So the patient is wet and cold, so hypoperfused and congested. And what do we call this phenotype?
It's cardiogenic shock.
Perfect. Excellent. So this is the last phenotype of acute heart failure, which is the cardiogenic shock. Mainly, there would be a severe cardiac dysfunction, a systemic hypoperfusion causing these symptoms. Of course, the signs and symptoms of systemic hypoperfusion would be basically decreased mentation, decreased urine output, and also low blood pressure. So these are the signs or symptoms that we can see in those, or this is the evidence of hypoperfusion. Of course, by labs also we can see if there is high lactic acid, shock liver, and other signs of end organ hypoperfusion. Usually the onset is gradual or rapid. It depends. It can be either of them. And the main treatment would be inotropic support and also mechanical circulatory support. So this is basically the algorithm. It is self-evident that if the patient has any underlying acute coronary syndrome or any mechanical complication, of course we need to treat that accordingly. But if not, we need to just start the general management, which consists basically of oxygen or ventilatory support if needed, inotropic and vasopressor support, this is class 2B, and also mechanical circulatory support, it is class 2A in this condition. If there is improvement of hyperfusion and organ dysfunction, then we wean off these treatment. If not, we will go on and we might need also renal replacement therapy. And lastly, would be considered for palliative care. So don't worry if you are not following with the management. We'll talk about each management separately in details. I just went through the management quickly now, just to for you to get familiar with it. But we will discuss it in details in few moments, inshallah. Okay, so this is the general management of acute heart failure. We just went through the algorithms. Any questions so far? Am I going so fast or?
No, it's clear, boss.
Oh, okay. So let's start with the general management. So the management is actually generally subdivided into 3 stages. So it is the pre-hospital stage, in-hospital, and pre-discharge stage, pre-discharge phase. And each one of them has its own goals and approaches. So the management of acute heart failure actually starts not only when the patient arrives to the hospital, but it should start even when the patient is at home. In our hospital, the patients who are known in our clinic, they have actually a WhatsApp number where they can contact whenever they have worsening symptoms. So the management, as I said, can be started even at home. And this is actually in the European guidelines, it is recommended to start the management even at home. So basically, the management with measuring the pulse, the pulse oximetry and the blood pressure, and titrating the Lasix doses can be started at home. And if it did not result in any improvement, then the patient has to present to the hospital. This will lower the number of those patients requiring hospitalization, and this will lower the cost, of course. We'll go through each stage and each therapy. So let's start with oxygen therapy first. So oxygen should not be used on those patients who are not hypoxemic. And this is actually class 3 recommendation in the guidelines, not to it is harmful rather to start oxygen for those who are not hypoxemic patients. Anyone can tell me why, or anyone can guess why?
Oxygen can cause vasoconstriction. It reduces cardiac output.
Perfect. Yeah, exactly. So oxygen is like any other medication. It has its own side effects as well. So it can increase the oxidative stress, increasing free radicals, resulting in, as you said, vasoconstriction, and this will result in reduced cardiac output.
It's toxic.
Yeah, exactly. So so we should not start patients who are not requiring oxygen on oxygen, because it can be rather harmful. So it is only recommended for those patients who have oxygen saturation less than 90% or partial pressure of less than 60 to correct their hypoxemia. And we need to make sure to really beware those patients who are COPD, because we should not increase their oxygen to higher levels. The oxygen saturation target should be between 88 and 92% only, because their respiratory drive is mainly driven by the by oxygen rather than the CO2. So we need to be careful in those type of patients. If the patients are also not improving with oxygen supplementation, we need to consider non-invasive positive pressure ventilation, especially for those who are tachypnic, whose respiratory rate is more than 25 breaths per minute, and their oxygen saturation is less than 90%, despite the conventional oxygen supplements by nasal cannula or non-rebreather. And lastly, if the patient is not improving, of course, with non-invasive, the last resort will be intubation. Then we move to the cornerstone of the treatment of acute heart failure, which is the diuretics. Unfortunately, there is no clear data about the optimal dose of diuretics and of Lasix or diuretics in general in patients with acute heart failure. I think we all heard about the famous trial, DOSE trial, which with all its limitations, it has a very it has many limitations, including low sample size, small sample size, and so on. But we could have some conclusions from this trial, which I summarized here. Basically, it showed that no difference in the primary efficacy outcome of patient symptoms global assessment between those who received high dose regimen compared to those low dose regimen. So there was no major difference in outcome between these two groups. However, there was a greater relief of dyspnea, change in weight, and net fluid loss with no prognostic role for increase in serum creatinine in the higher dose regimen. And therefore, the conclusion was that it might be appropriate when starting IV diuretic treatment to use low doses, but then to assess the diuretic response and increase the dose when that is insufficient. So the dose trial really did not help us a lot with determining the appropriate dose because there was no really major difference between those who received high dose or those who received a lower one. I find this algorithm very, very helpful, and this is also one available in the European guidelines. It really gives us just like a roadmap on how to initiate the IV diuretics in patients coming acutely to the ER. So if those patients who are naive, who are not on oral loop diuretics at home, then we will start with 20 to 40 milligram of IV furosemide. But for those who are already on loop diuretic at home, then we will start them on the same dose or 2 times the dose, but IV. And then we need to measure the response. So we have two ways. Either we measure the urinary spot sodium, which is not very feasible, after 2 hours. If it is more than 50 to 70, then this is an adequate response, or by the urine output. So if it is after 6 hours, it is 100 to 150 ml per hour of urine output. This is considered an adequate response. So what we do in this case, we just repeat the same dose, but Q12 hourly, every 12 hours. But if not, the dose is not adequate, then we will either double the dose or until reaching the maximum dose. And then we measure the response by either urine spot sodium or urine output. If it's still not adequate, then we will consider adding another diuretic, for example, metolazone, a thiazide-like diuretic. Or if it was adequate, then we will just continue with the same dose with just more frequency or more frequently administered dose. I think this is what I found the most useful algorithm in the guidelines regarding how to initiate patients on or what dose to choose when managing those patients. So this is about diuretics. Moving to vasodilators. So intravenous vasodilators can help in relief of symptoms, and we mentioned this already, especially in those who are presenting with a flash pulmonary edema due to high blood pressure, due to a hypertensive emergency, because their pulmonary congestion is mainly because of fluid redistribution. And the management would be decreasing the afterload by vasodilators, then along, of course, with diuretics. However, 2 recent randomized trials comparing the usual care with diuretics with early intensive and sustained vasodilation actually failed to show any beneficial effect of IV vasodilators compared to high dose of diuretics. But again, we should choose wisely those patients who are expected to benefit from vasodilators, and especially those who are having blood pressure systolic blood pressure less than 110. Of course, we need to avoid vasodilators by all means to avoid any further hypotension. Then we move on to the inotropes and vasopressors. So they are still needed for treatment of patients with low cardiac output and hypotension, but they should be reserved for those with LV systolic dysfunction, low cardiac output, and low systolic blood pressure, resulting in poor perfusion. But they must be used with caution because they are not without side effects. Those with severe hypotension, the best inotrope or vasopressor would be norepinephrine in case of cardiogenic shock. So we have different inotropes. Again, they are not without side effects, and that's why they should be chosen wisely. For example, dobutamine can cause a peripheral vasodilation, and that's why it might even worsen the hypotension. So it should be avoided in those with very low systolic blood pressure. Dopamine is the same as well, and milrinone as well. All three can cause peripheral vasodilation, and that's why it should be avoided in those with severe hypotension. Also, we need to remember that they are very arrhythmogenic medications. Milrinone can cause like tachyarrhythmias, including AFib and so on, and also the same applies to dobutamine. The most, as we mentioned just now, the most effective vasopressor in those with severe hypotension and cardiogenic shock would be norepinephrine. Of course, to discuss each inotrope and vasopressor, it would take a whole session or a whole talk to talk about it in details, but this is just a brief introduction to this topic. Then the next modality or treatment or management of acute heart failure is the opioids, which used to be one of the treatments in the past. However, it is now the routine use of opioids now is not recommended, but it can be useful in those patients who are on non-invasive ventilation, for example, just to improve the patient adaptation to the to BiPAP or CPAP, for example. And it can be used also for those patients who are for palliative care. Also, it can be recommended. However, the routine use of opioids on those patients with acute heart failure is not recommended now. Digoxin, of course, also it's not recommended to be used routinely, but it is particularly beneficial for those with fast AFib, despite beta blockers, and also are presenting with acute heart failure. And then lastly, thromboembolism prophylaxis. This is very important. This is class 1 indication. Any patient who's admitted with acute heart failure in the hospital should be started on prophylactic for thromboembolism. If not, they are already on therapeutic anticoagulation. Then the last modality or management modality of acute heart failure is the short-term mechanical circulatory support. So also, the routine use of this modality of management is not recommended. It is recommended only in certain patients, and especially those with cardiogenic shock. Especially intra-aortic balloon pump can be considered in patients with cardiogenic shock as a bridge to therapy, bridge to destination, or bridge to bridge, including the treatment of the cause of the cardiogenic shock as well. But intra-aortic balloon pump is not routinely recommended. This is actually class 3 to be used routinely in cardiogenic patients, especially those post-MI, but it might be considered. A very useful profiling classification of the patients who are requiring mechanical circulatory support is the Intermax profiles. This is basically just a classification of patients according to the indication for mechanical circulatory support, because what they found that the NIHA classification, for example, is not useful in those type of patients. So they came up with this profiling, where the Intermax one, those are the patients who are mostly, or they are strongly recommended for mechanical circulatory support, and the indication or the strength of the indication will be less and less as we go from Intermax 1 to Intermax 7. Lastly, I just want to touch base on the invasive monitoring of heart failure patients. So invasive monitoring by pulmonary artery catheters used to be widely used in the past. However, a big trial, which is the ESCAPE trial, showed that among patients hospitalized with recurrent heart failure, but without an established need for pulmonary artery catheter, the use of this invasive monitoring was not associated with any reduction in days, neither of death or hospitalized patients or hospitalization. So that's why the data did not support the use of invasive monitoring in all patients with acute heart failure. However, in those patients who are they have unclear picture, for example, a mixed picture of shock, for example, septic or versus cardiogenic shock, and the diagnosis is not clear, an invasive monitoring can be useful, but it is not routinely recommended. Lastly, I will just go through the pre-discharge assessment. A significant proportion of patients with acute heart failure are discharged with minimal or no weight loss, and more importantly, persistent congestion. And that's why they come again rehospitalized very soon. And that's why we need to optimize the treatment of those patients before discharge. And we have to have 3 goals to achieve. So the first goal is to relieve the congestion. The second is to treat the comorbidities. And thirdly, to initiate or restart oral optimal medical therapy with beneficial effects on outcome. So these are the 3 goals of treatment before discharge of any patient. So studies showed that such optimization of medical treatment is associated with a lower risk of 30-day readmission. Initiation of some medications, like for example, ARNI or SGLT2 inhibitors, have been strongly recommended in patients who are to be started even before discharge. This is just an example of the what we use in our hospital regarding the heart failure discharge summary checklist. It is a very useful checklist. If you guys want to, if you don't adopt a similar thing in your hospital, I would really encourage you to do it, because it reminds us of many important aspects before discharging the patient home, and it is basically a checklist of most of the things that we already discussed, but in an organized way. Follow-up after discharge. It is recommended to have one follow-up within 1 to 2 weeks after discharge. And the components of follow-up visit should include assessing the symptoms and signs, the volume status, of course, the vital signs, including the blood pressure and heart rate, and some laboratory measurements like the renal function, electrolytes, and the natriuretic peptides. And iron status is very important because it, as I said, it has very important prognostic implication. And based on the clinical evaluation and laboratory exams, further optimization and or initiation of medical therapy should be started. So those patients, some patients are more susceptible for readmission than others. Those patients who are having CKD, have low systolic blood pressure, diabetic, COPD, those who have persistent symptoms, are more than 7 medications. Also those who have history of substance abuse, frequent previous admissions, multiple comorbidities, depression, dementia, and also infections like HIV, cancers, and also those who have poor social support. All those patients or all these factors predict a higher rate of or a higher risk of readmission. And as you can notice, these are actually very rarely to find any heart failure patient without any of these risk factors. And that's why the readmission rate for this population is very high. This is just, I put the summary of the recommendations just in 2 slides. So you guys can go over it. I don't want to spend much time. I'm already over time. I don't want to bore you with the details of the recommendation. I will provide you, inshallah, with the slides, and you can review it to your convenient time. So just any questions so far, and then we will start with just a few MCQs, and then we will call it, inshallah. Any questions?
No question.
Okay. So let's just go over some MCQs. Who wants to take this one?
I can take it.
Okay.
You have to read it, yeah?
Yeah. Okay. I'll read it. It's fine. A 45-year-old man, known case of non-ischemic cardiomyopathy, presented for second time in a year for increased shortness of breath, blood pressure 130/80, heart rate of 100, respiratory rate of 24, JVP is elevated at 16 centimeters, normal S1 and S2, no basal crackles, no lower limb edema, sodium is 140, BUN is 24, and creatinine 1.3, and cardiac enzymes are negative. ECG showed no changes from baseline. So based on the initial assessment, how would you classify his hemodynamics? So is the patient warm and dry, which is profile
this
A?
patient is warm and dry.
Okay. So again, we will just you said
it's not dry, right?
Yeah,
it's
so
wet.
yeah, exactly. So the patient is having
It's
short
warm,
sneezes, and has also crackles. It has no basal crackles, but he has symptoms.
But high JVP also.
High JVP as well, yes. So
Yes.
this is actually warm and wet.
Yes, it is not dry. Yes.
Yeah. So it is a bit confusing. Not all patients who are the reason why I brought this question, just to show that not all patients will come with frank lower limb edema to call them wet, because it requires 4 to 5 liters of additional fluids for the lower limb edema to be noticeable on the examination. But sometimes patients will present mainly with symptoms of pulmonary congestion, like in this patient, and this would be the evidence of congestion, and that's why they are warm and wet. So here we have the JVP is high, and also
yes, even though there is no crackles, there is no basal crackles, so the lung seat is not really that wet, but still there is high JVP.
Exactly. This is basically what we went through. This is just from the American guidelines. So profile A is warm and dry, profile B is warm and wet, profile L is cold and dry, and profile C is cold and wet. So let's go to the second question. So this patient, the same patient, was taking furosemide 40 milligram BID, lisinopril 5 milligram, and carvedilol 25 BID at home. Which of the following would you choose for your initial therapy at the hospital? Oral furosemide 80, IV furosemide 20, IV furosemide 60, milrinone, or dobutamine? So anyone?
C, IV furosemide.
Perfect. Yes, exactly. So according to the American guidelines, so heart failure patients receiving loop diuretic therapy should receive an initial parenteral dose greater than or equal to their chronic oral daily dose, then should be serially adjusted. So the patient was already on 40, so either the same dose or just a slightly higher dose, and that's why the right answer is 60. Let's go on to the next question. So overnight, the same patient, he did not diurese very well. Creatinine remains stable. Which of the following would you recommend? So add low-dose dopamine, start ultrafiltration, add milrinone, stop IV furosemide and start torsemide oral, or increase IV furosemide to 120 BID.
A. Add low-dose dobutamine.
Okay. Anyone else?
I will increase the furosemides.
Okay. Yeah. Excellent. So this is actually the answer.
Yes, so increase the furosemide.
To increase the furosemide. Why? Because the patient is still stable, not hypotensive. So according to the American guidelines, again, so when the diuresis is not adequate, it is reasonable to give higher doses of intravenous loop diuretics, or add a second diuretic, which is thiazide. Then, if that did not work, then ultrafiltration or Other modalities like dopamine or inotropic or vasopressors can be started. But the patient is like in our patient, the patient's hemodynamics are fine, and just the diuresis is not adequate. The second step would be increasing the dose rather than starting a new medication. So after you increase the diuretics dose, the patient is producing a good amount of urine. Which of the following is true in regards to the use of beta blockers in this setting? A, carvedilol should be discontinued throughout the hospital stay. Carvedilol should be switched into metoprolol succinate, or the patient should be on beta blockers at the time of discharge if euvolemic and hemodynamically stable. Or lastly, the patient should be placed back onto beta blockers when he is seen in the first follow-up and found to be stable.
C.
C.
At the time of the discharge, if the patient is euvolemic.
Yeah, excellent, excellent. So this is also according to the guidelines. So initiation of beta blockers therapy at a low dose is recommended after optimization of volume status and discontinuation of intravenous agents. It can be started during hospitalization before the discharge. We should not we don't have to wait until the patient is discharged and followed up in the clinic to start or resume the beta blockers. Last question. So the patient achieves euvolemia and you are preparing him for the discharge. Which of the following would you recommend? Schedule follow-up visit within 1 month, refer him to heart failure disease management program, place a PICC line for outpatient intermittent milrinone infusion, add ivabradine if heart rate is more than 70 while on beta blocker, or send genetic testing to improve post-discharge risk stratification.
B, refer him to congestive heart failure disease management program.
Excellent, excellent. Yes, exactly. So follow-up according to the American guidelines, a follow-up visit within 7 to 14 days or a telephone follow-up within 3 days of hospital discharge is reasonable. And the patient should be followed in a heart failure disease management programs, referred to heart failure disease management programs. So this is class 1 indication. The other choices are not accurate. So this is basically everything. I'm really sorry I've been long. I hope I did not bore you with the presentation.
It was a great presentation, really, sir. Thank you for that. Really, yes, that was precise, straightforward to the point, and thank you for it, really.